Welcome everyone to today's program. I'm Lindsay Dunn, Editor-Chief of Becker's Hospital Review and the moderator for today's program. The program will begin with a presentation and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have today, and they will follow up on any questions that they don't have the opportunity to address. After the presentation is completed, within about a week you will receive an email with instructions for how you can download a copy of the presentation. You'll also receive a follow-up email shortly after completion of today's program where you can submit your feedback, and if you have any additional questions, you can send those to the presenters at that time. It's now my pleasure to introduce today's presenters. The first presenter is James Stafford. He is a client service executive for Objective Health. With more than a decade of experience serving organizations across the healthcare sector, James helps to orchestrate the full range of Objective Health's products and services to ensure that clients achieve their goals. James' recent work with hospitals includes a comprehensive performance transformation engagement for a multi-hospital system, an accelerated margin improvement program for a large independent hospital, and a physician alignment strategy for a regional health system. His experience in other healthcare industries includes designing and launching a shared services business unit at a health insurer and creating a new physician reimbursement model for a regional payer to improve quality, eliminate unnecessary hospitalizations, and reduce total healthcare costs. Our second speaker is Amit Shah. Since joining Objective Health in 2008, Amit has focused on serving payers and providers on healthcare value. He leads the firm's knowledge development in care and payment innovation. He has supported clients across the healthcare value chain on payment innovation from strategy development to contract design and negotiations to implementation. It's now my pleasure to turn the floor over to Amit to begin today's presentation.
Thank you, Lindsay, and thanks everyone for joining. So what I thought I'd do today is really start by teeing up a framing of one way to think about population-based models. And once we kind of have that grounding in some of that basic thoughts, that we would then go into, what are we seeing in the market, and specifically looking at a specific case example or case study. So if we can please go to the next slide. What we see here is, so what is our understanding of population-based models? Right? As we think about it, some of the key goals are around achieving the best possible quality at a minimum necessary cost. It's really about shifting mindsets, right? So from the patient in front of a provider to the entire population for whom they're responsible. And frankly, this, in one bullet, really kind of is an indication to something that is much bigger and broader, a fundamental change in the way providers and the delivery system think about care. Then this kind of notion of effective collaboration. So this could be across settings of care. This could be amongst primary care providers. Then this idea of reducing unnecessary hospital admissions, ER visits. Now this is not meant to be comprehensive, but rather illustrative of some of the key sources of value. And I think if I just kind of look at this last bullet point here, improve wellness and preventative care, the idea here really is that it's to go beyond, I think, as one of our colleagues and clients in Arkansas says, to go beyond the numerator, but really think about denominator medicine. How do we think about preventing disease progression, not only curing and treating? So if that's a kind of a basic setting for what are the goals and what's our understanding overall of population-based models, if we can go to the next slide, what does this actually mean for stakeholders, right? What's in it for them? What you see on this page is by no means meant to be exhaustive or comprehensive, but rather examples of what specific stakeholders may actually value. Now, an important caveat here, of course, is that the specific model and its design that's in place will impact the exact value proposition. But let me highlight a few. So on what you see on the left-hand side are examples for patients and what it means for patients. And if you look at the third, this is around this notion of kind of preventing avoidable admissions and minimizing readmissions, ER visits, et cetera. So, where our belief is that we're at a time in healthcare where, in many ways, both quality, experience, and cost of care are aligned, and I think this is a great example. So, I think most patients would agree that they'd rather not be in the hospital, and so to the extent that population-based models can really avoid some of these unnecessary utilizations, it's both a boon to patients as well as the system. I think, another one just to point out here is around improving access. And so, again, if successful, this improved access can both be a benefit to patients as well as a real opportunity for providers. So, we've heard some kind of primary care practitioners, I think especially in kind of the fragmented market, say that new solutions for access, so for example, group visits, and when I say new, that's new to the specific office, not necessarily a novel concept, but really embedding group visits into their kind of day-to-day or week-to-week business ensures or allows patients to feel like they have greater access to MDs. But in fact, these group visits are oftentimes actually primarily run by the care team overall. So you also kind of have this ability to maximize the time and efficiency of a physician's time with patients, and kind of this notion of allowing the care team to practice at the top of their license. If we look at providers for a moment, again, the value proposition will vary by model design and by provider type in many instances. But physicians may benefit from tools and infrastructure that facilitate communication. So much of the time that physicians may spend today, which they would believe is kind of administrative or just kind of wasted time, to what extent can these population-based models, by embedding new infrastructure, by creating new collaborations between providers, actually improve the efficiency of care for providers themselves. And if I take one example of a system view, overall these models really provide an opportunity to address all care, right? Total costs and a broad reach of care. And so what this means from a system view, if done appropriately, is really effective management of funds. So again, I think there's a lot that we could talk about on the kind of value proposition, but I just wanted to highlight a few examples of what this could mean for various stakeholders. So if we then go to the next slide, please. So we talked a little bit about the goals and what is the value proposition of these models. So how do these models fit with the rest of the system, with all the other moving pieces? And it's our view that the universe of these models are actually quite complementary. So what you see over here, if you kind of focus on the middle of this page for a moment, so population-based models at the top, examples including patient-centered medical homes, ACOs. In the middle here you have episode-based models and different types of payments related to that, and the bottom fee-for-service. So our overall belief is that each one of these models and types of payment have a role to play. And what you see on the right-hand side are some examples. So they're most applicable in different areas of care. So population-based models potentially more focused on kind of primary prevention, on care for the chronically ill, versus episode-based models. Although we're seeing in the market kind of an extension of kind of where episodes are applicable, I think they're still kind of really around acute procedures, really thinking about to what extent can you take an inpatient stay as well as 30, 60, 90 days post-discharge and define that as an episode. So our view is that that these are quite complementary, in part, as I just described, based on the kind of conditions and diseases and patients they target, in part based on the value that they target. So again, kind of population-based models focusing on things such as prevention in addition to others. Episode-based models, in many ways, kind of focusing on the efficiency of a specific encounter. So with that context, what I thought I'd do is go to one more slide here, and say so if these are the goals, this is the value proposition, and this is how it all fits together. What are the building blocks of population-based models? And so what we're seeing here is kind of three broad building blocks. The two pillars and then the bottom set of enablers. And so what I'll refer to this in many ways as kind of the what of population-based models. So the what, if you look at the top left here, the left pillar, this includes risk stratification and alignment of care type pathways and intensity of care to the level of need. For example, this may mean defining the population for whom the care coordinators may actually spend 75, 80, 90% of their time. The second one on the top right, or the right pillar, this is around the care model and care team approach. So as you'll see, this includes a broad range of things, so including kind of the clinical protocols and packages, and this is really around ensuring evidence-based medicine. Then care plans and tools. This is to allow for integrated proactive care. Case conferences. So this notion of improving care for patients with complex cases, and really in part by introducing a multidisciplinary team. This is an interesting one. I think very clearly in hospital systems we see this, whether it's M&M conferences, several different flavors. But what we've been finding is in kind of population-based models more broadly. So even in kind of the fragmented primary care system, that these types of case conferences, embedding this into your population-based models, actually can drive real impact, especially for those kind of sickest or riskiest patients. And then number 4 here, the performance review. This notion of a culture creating a culture, and I think more tangibly processes such as transparency that encourage continuous assessment of performance and continuous improvement. And on the bottom here, I won't go into each one, but this is the notion of the third building block is around these key enablers. And this ranges from aligning incentives and reimbursement models to what is the type of information that you can provide that will really drive decision making, that will drive a change in the way physicians and the delivery system can care for patients. So let me pause here for a moment and just explain. So I call this the what of population-based models. And the rationale for this, which we'll go into in more detail in this second section, is really that for each one of these 3 building blocks, the keys to success lie under the hood. So it's the how that differentiates successful models. So we'll go into this more in the next section, but if I can just provide an example for now. So if we look at the left pillar here, one of the core building blocks, superficially, risk stratification may seem like a fairly straightforward exercise, but in fact, when you get under the hood, there's actually several design decisions that influence, how stakeholders perceive the risk stratification, how they react, and how they, whether or not and how they will change their behavior. So, your impact comes from some of these underlying design decisions. So an example, should you use a commercial algorithm that has potentially higher R squareds, a commercial risk adjustment algorithm, that is. But the trade-off is that it may very well feel like a black box, right? So do you use demographics, do you use age, et cetera? So, this in some way is clear, right? I mean, it's not some sophisticated algorithm, but most, generally speaking, is less accurate. Should you use prospective or concurrent risk adjustment? Right? One allows for significant clarity up front and understanding of who the patient population is, but just may not be as accurate, especially if you have fluctuating patient populations. The other has the benefit of accuracy, but then provides little guidance on actually who to target and how. So I'll pause here. I think I just kind of gave 2 examples around choice of algorithm and this notion of prospective and concurrent. Those are long discussions that we can get into again in kind of the Q&A. But I just wanted to really give a sense of, as kind of there's a growing understanding of the what, it's kind of this what underlies some of the core decisions around the how that will really drive success of these models. So if we go to the next page for a moment. So we're actually going to just pause here for a moment and take a poll. I think if you can select one of the answers that are on the screen there. Looks like the poll is in progress, and we're beginning to get some votes here. So we'll give it just a few more seconds. Gee, the votes are coming in quite quickly, so I might give it a little more time. Maybe another 15 seconds or so. We're up to about 70% of those joining today have voted. All right, starting to taper down here. So we're at about 80% voted. Maybe we can show the poll now. So interesting. This might be one for us to come back and discuss. You know, maybe a bit skewed towards incentives and reimbursement, but really across the board. A belief that there's real challenges across several of these key enablers. Maybe we can move on to the next page, please. So, as I mentioned, the first section was really around teeing up some of the basic thoughts and really framing what population-based models are. And now what I'd like to do is spend a little bit of time diving into what are we seeing in the market, and particularly from payers. So if we can go to the next page. So as I think many of you are aware, and probably many are participating, there's kind of tremendous experimentation and buzz in the market when it comes to payment and care model innovation broadly. And so to give you a sense of what that is, on the left-hand side here, our team has just conducted a basic analysis to understand the prevalence of some of these keywords in press releases, earnings calls, et cetera. And suffice it to say, people are definitely talking about this. And I think what's interesting here is, you see ACOs pop up as one of the kind of key terms. And for those of you that haven't seen a graph or chart like this before, the kind of larger the size of any one of these terms, the more often or more frequently we've seen this term actually show up during this search. So you see ACOs, you see population management there as well, provider collaboration. So many of these oftentimes kind of synonymous. On the right-hand side, what we see is that not only is this in press releases or people talking about it, but this is actually getting into budgets. These are part of strategies and getting into action. Now, no question, different payers and different providers are different kind of steps within the journey, but nonetheless, several players are pursuing these. And interestingly, I think this gives you a snapshot of care and payment innovation more broadly, so population-based models as well as bundled payments. And as you kind of dive into some of these, you'll see that their strategies and approaches are quite different, and that's in part based on what their underlying goal is. So for some, it may very well be, this is a proactive, we believe the world is changing and we're part of that and we're leading. For others, it may be much more strategic, almost a defensive move, which is to say, we can leverage population-based models in our markets to either secure volume, either it's a different approach to narrow networks from a payer's perspective that they may not be able to really pursue at this time. So, although many of these payers are kind of pursuing similar models at the highest level, their underlying intentions and therefore their detailed design are quite different. If we can go to the next page, please. So if that's the broad kind of, there's quite a bit of experimentation. If we zone in for a moment on population-based models, what we're seeing is, 4 broad approaches. So this notion of payer-led, hospital-led, IPA-led, and community-led. That's going down the left-hand side of the page there. So payer-led, I think some very public payer-led. So Care First, for example, this in many ways, I mean, it was a statewide rollout with quite a bit of upfront payment available for providers, and really pushed by Care First and other payers as well in that market. And so, there are of course several underlying reasons for payer-led to, or for that payer to lead. But as you think more generically, there are some kind of market or contextual factors that favor this model, and a big one is around payer market share and provider materiality. So, just to get in the head of some of these payers for a moment, I know there's quite a few kind of folks with a provider background that are listening in. This notion of payer market share and provider materiality, the idea is, you have to kind of have a meaningful share of a provider's patient panel overall to really influence and enact any sort of change. So, a 10% market share, is that really enough to ask someone or ask a physician or a group of providers to fundamentally change their behavior? And so payers, think quite a bit about, what is that market share, and then, associated with that, what's the provider materiality? So what does this mean from a kind of patient satisfaction experience and care side? What does it mean from a financial sustainability viewpoint? And, a big piece that I'd call out here as well is around payer capabilities. So we started to get into some of the kind of discussion around risk adjustment, et cetera. So these require real capabilities on the payer's end, and a belief and understanding that, this will move from version 1 to 2 to 3, et cetera. So I won't go into each one of these below in significant detail. Maybe what I'll call out is, if you look at the third here, so IPA-led risk-bearing contracts. So we are seeing quite a bit of experimentation that's being really pushed by real innovative, primary care physicians and real strong clinical leadership that are driving a variety of models, whether that be ACOs, whether it be, a real kind of shift towards a strong, almost PCMH with either a strong or slowly integrated medical neighborhood that really can care for the sickest patients, such as Chen Med. And then there's examples such as community or community-led examples. So the Camden Coalition, I think Jeff Brenner, some of you may know. So really incredible work here, but really thinking about targeting a small geography and the highest risk patients in a way that really leverages community resources and a really strong emphasis on data and understanding of the specific patients in that population. Let me go from here and actually to the next page, and we'll double click on basically that payer-led row that we had just begun discussing. And actually before that, if we could try another poll here. So it should have just come up on your screens. And again, if you can select one of the answers here. All right, we're about 50%. We'll give it another 15 seconds. All right, we're reaching that 75% again, so maybe we can show the results. Great. I think this will definitely be an interesting discussion. It looks like, in general, you see the payer and hospital-led, those being kind of equivalent, but then really this notion of, this requires a multi-pronged approach here. So maybe we can go to the next page and show an example of this payer-led population model. So this is meant to be a case study. It's a blinded example, and so what I'm really presenting here is the kind of viewpoints and context that this specific payer thought about. And so On this page, really just want to call out two things. So the perception of this payer is that primary care providers are in many ways a great position to really make a change in healthcare. Although the dollars spent on primary care services may only be 3 to 5% of total cost of care on average, they actually have the opportunity to influence almost all spend, and this may be directly or may be kind of via referrals. On the right-hand side, the conundrum, as this payer would say, is that in some sense they may be least capable of doing so. And this is because of potentially a small scale. It may be just related to that small scale, the administrative and daily small business burden. And oftentimes, somewhat constrained just by kind of informal affinities and ties with either patients, families, or other providers. So with that kind of brief framing in terms of how this payer was looking at it, if we flip to the next page, please. What this payer described is, as they think about their population-based model, and in this case specifically around patient-centered medical homes, they said, look, on the left-hand side, we have 3 real goals around impact. So first is around improved care and quality and patient satisfaction. From the provider perspective, they actually believe that they needed to, in their model, design payment in such a way that there was a material increase in take-home compensation. And lastly, as they highlighted the system impact, in their mind was, 10 to 20% of savings they felt was really achievable. And what I'd call out here is that as they thought about where the savings came from, they differentiated between kind of direct PCP decisions or savings that they believe stem from an improvement in primary care practice patterns versus savings or value that can be driven from essentially referral to efficient providers. So this notion of, can we arbitrage between existing performance dispersion today to capture some value today and in parallel really create performance pressure for non-PCPs, or literally anyone in the delivery system, to improve their performance. And so, this is an approach that is specific to this payer. I think, we are seeing it more and more often in terms of at least, looking into the possibility of what does this kind of ability, or if referral autonomy exists, what is the real value of that? And so if we skip to the next page, so with this context, they thought about 3 payment streams. So fee for service, care coordination and transformation support fees, and performance-based payments. Now, I've listed here a few of the payer's considerations, but won't go into significant detail on all of them. But thought I would highlight performance-based payments for a moment. So, the first, they consider the various forms of kind of performance or outcomes-based payment, and in their case, the set included kind of a pay-for performance based on utilization metrics, then upside gain sharing only, and then a kind of symmetrical or upside and downside risk sharing. What the critical question to them was around, what is the capability of the payer and the provider? So what is the real readiness of the system to do downside risk sharing? Second, what they really, and so where they landed was upside gain sharing only to begin. The second kind of series of questions was really around, how do we deal with absolute improvement and performance improvement? So what they said is they began by developing a set of guiding principles and really said that, look, the trade-offs here are important. Absolute performance, if it's truly creating value in the system, so it's risk adjusted, then their feeling was it should be rewarded. However, what do we mean by absolute performance then, right? Is this about total cost of care, utilization? Is this about process improvements? And the real challenge here is that if it's about absolute performance, the system as a whole may actually be net negative. You may not be creating any new value in the system. And so that payer, as they think about their funding, may actually not be able to sustain this. On the flip side, performance improvement creates real value for the system, and all practices can achieve this. So whether you're starting it off at kind of a strong position or a high value provider system or not, you have the ability to improve. Now, the key thing here is that it's improving against each practice's historical baseline and a trend. And so, because it is against trend, this, the notion of, at some point you can no longer improve, that may be a misconception if you're really going against trend. The last thing I'd highlight here is, is quality. And the belief of this payer is that quality must be embedded throughout this model. And the question is, how then do you do this? Is it a separate payment, or is it actually somehow impact the performance-based payments and care coordination, et cetera, themselves? And so in this instance, the idea really was that, could we use kind of a tiered model such that your gain sharing for performance-based payments was actually impacted by your quality performance? And so obviously a lot of detail to go in here, but wanted to give you just a little bit of a sense of where this group ended up, which is upside gain sharing only, a belief that you really had to mix absolute and performance. And so to some extent the payer or the system is taking kind of a funding risk. And lastly, that quality was essential to really tier the total amount of gain sharing, or the percentage gain sharing available. If I can move on to the next page and just give one more example. So as this payer thought about how they could support providers in the delivery system, payment was one piece of it. The second was really around supporting practice transformation. Now, after quite a bit of thought around the different ways that you could potentially support practices, specifically understanding that practices and providers will start in different places. Their belief was that there's 4 options, and in this case, they thought 4 complementary approaches. So the first was this transformation guidebook. So they actually created a guidebook co-created, I should say, with providers in the market, and the idea was to really not provide a prescriptive, but rather guidelines and guardrails for how could you transform, how have others in the market done so, and how do you create a kind of a performance-based culture, a continuous improvement culture. So this guidebook was meant to target multiple audiences, so the PCPs as well as care coordinators and other office staff. The second was around transformation coaches, so really providing kind of the knowledge and skill set where available. The third is learning collaboratives. So I think we're hearing more and more of this over the past 5 to 7 years. And so to the extent that you can really share knowledge across providers and have providers learn from each other, this payer saw tremendous value in that. And then the fourth is this kind of notion of physicians as general agents. This idea that there are some early adopters, and to what extent do those early adopters or general can they act as a general agent? Can they act as a real catalyst for a greater understanding of PCMH across providers, across patients, and to what extent can they actually help other practices transform? And so as this payer thought about it, they looked at all 4 of these options and really pursued each one of these in order to provide the right amount of support. Again, their underlying belief was that that incentives are necessary but not sufficient, and several of these support approaches were critical based on the feedback that they received from providers. And so if I can flip to the next page, what I'll do here is just step back for 1 minute. So we spoke a little bit about a case study, but if I bring us back to the 3 building blocks, what I mentioned is that experimentation has definitely led to a growing understanding of what it takes to succeed. So I think you're more likely to hear about these kind of higher level concepts. But if we look at the next slide, it is getting the how right. That's what's really going to drive success. And so I've taken 2 enablers here, and just kind of wrapping up by saying, I think we've heard a lot, right, when we think about incentives, this notion of, people may say robust payment models that incent quality, experience, and efficiency. What's interesting is that as you think about the how, this is often where programs may fall. So, what is upside? What is meaningful when it comes to upside as a percentage of total take-home compensation? So you may create a great payment model that has the right balance of absolute and performance improvement, et cetera. But what is the net impact to providers? Have you thought that through? An interesting one here is if you look at the fourth bullet point, this notion of how are you explaining the payout? So we've seen payment models now that, in fact, in many ways, seem, and from a provider's perspective as well, seem to kind of strike the right balance between the various options. But at the end of the day, it was communicated in the form of a PMPM, for example. And you had providers literally, saying, or people in the delivery system saying, this doesn't really seem compelling. And really the fault here, the pitfall here was in the way it was communicated. So some of the kind of the co-creators and counselors to this payer, said, look, we don't think in PMPMs, and frankly, what we want to know about is what is the impact to our take-home compensation. And so literally that small switch in terms of communication changed, really pivoted kind of how successful this program was. So let me pause there and hand it off to James.
Thanks, Amit. Yeah, thanks very much for sharing that structure and those examples. And what I'd like to do is describe at a high level how providers I've seen are approaching population health. And so with that, let's move on to the next slide, please. So as providers plan for the future, we think the industry should keep in mind 3 different horizons. So the first horizon is a period of regulatory turbulence that's taking place right now, and everyone's very familiar with that right now. And roughly through 2014, as the fundamental mechanics of reform are still being defined. And now that the Supreme Court decision, the recent elections are in the history books, you're starting to see the industry move into the next period, which is characterized by market turbulence. So this we think will reach its crescendo 2014 to 2016 as the war games play themselves out among all the payers and providers in different markets. But we're already seeing signs of this as M&A is picking up. Also, we at McKinsey keep a national catalog of experiments that are underway across the country, and this catalog is just going faster and faster. What's happening is that providers are recognizing that it would be extremely important to hit the ground running in 2014, meaning that the strategic postures and functional capabilities that you'll need for the future need to be built today. So that after 2016, what we'll start to see, we think, is a new normal with a clearer sense of who the new market leaders are, the defined models, and frankly the disappearance of many outmoded providers who simply won't last long, at least as independent acute facilities. And I think back to what happened in Sweden after the Adel Healthcare Reform Act of 1992. So Sweden in 1991 was a deeply overbedded country, and then they placed population health management in the hands of the municipalities there. And today there are half as many hospital beds in Sweden as there were in 1991. So not necessarily a perfect example, but I think you get the sense that when population health methods take over, that they can have a significant impact on the acute facilities in particular. So on the next slide, please. As Amit described, payers are moving towards risk-sharing arrangements with hospitals to prepare for that market turbulence. And as you see on the examples on this page, it's happening across the Blues plans, the national for-profits, the government. And the quotes on the right are from conversations that I and others have had with leaders of these health plans who have very clear strategies for moving to greater risk sharing. And the one on the top right, I think, is interesting. It says, in 5 years, we want 100% of our members on some sort of risk-sharing agreement. Now, that was back in 2011 that I heard that. And what's important to note is that this movement isn't evenly distributed across the U.S., which is why you may not be seeing these effects yet. And in that running catalog of experiments across the nation that I mentioned, we see significant activity in some of the obvious places like Massachusetts or California, but also in perhaps less obvious places like parts of Ohio, New Jersey, New York, Michigan, and Florida. But there are other markets, parts of Connecticut, Georgia, Mississippi, and many others, where momentum has yet to pick up. So there are markets where there's more experimentation going on, and there are markets where payers are largely sitting on their hands. But I've noticed that even in these less active markets, providers believe it's coming. And this is a departure from even a year ago. But I think the underlying basic math problem we face is getting clearer and clearer, and people are finding ways to prepare for that kind of future. So the next slide, please. The logic is driving providers to think through their own approaches to population health, no matter what kind of market they're in, really. And the process they follow is pretty simple, but it's got many different answers, as Amit described. So if the basic structure is very clear, how you actually fit your organization into that structure is far from clear. And so people are starting off by just asking, what is population health? And then the next question hot on its tail is, what's the right business model for me? And unlike in the past, where providers could be all things to all people, and most hospital strategies simply copied every other hospital strategy, the emerging landscape is forcing hospitals to differentiate from each other in meaningful ways. So then hospitals start to ask themselves, what are the priority areas where I could start working today? Where should I be in a year when the exchanges start opening? How will I be ready for the period of market turbulence that's coming, and how do I make sure that I'm part of the new normal and not just a casualty? So then comes the hard work of putting together implementation plans that manage the transition while not bankrupting the organization in a fee-for-service model. And then, of course, how do you track progress? Many of the key metrics are still undefined, let alone available with data, and very few systems talk to each other. So a lot of decisions to be made. Next slide, please. So when it comes to the implications to providers, I think providers are realizing they need a new set of capabilities. And this is, an inexhaustive list, but just some of the key things that I've seen when it comes to people moving from kind of a past orientation to a future orientation is that in the past, hospitals have been successful by focusing on physician recruitment, payer contracting, carefully balancing, say, profit-generating services and payers with money-losing services and populations, and a business-to-business mindset, as opposed to a future that rewards providers who manage clinical practices, operate in the context of integrated systems of care, manage risk for populations, who become known for specific areas of excellence, and who understand and can respond to their customers as business-to-consumer organizations do today. So let's go through each of these capabilities in a bit more detail. So next slide, please. So when it comes to clinical integration across care settings, it comes in many forms, and many of the leaders in this area are taking very different approaches. And so what we show here is just simply the different types of care setting areas in a very generic way, and the degree of integration that these areas and that these leaders are committing to. And so you've got examples like Kaiser. Their community care focus includes working with vulnerable populations through the government, through its own foundation grants to improve wellness and healthcare access, usually through case managers and primary care physicians. Geisinger brings community care services to expanded access points, such as homes, schools, workplaces. They also have some presence in social care, where at inpatient discharge, for example, they'll provide some access to social workers who help patients get access to additional, often government-provided services, as well as guidance on how to transition to kind of the needs of their new life. Partners, the most traditional provider on the page, they work with places like the Kraft Foundation to provide community health services. They have linkages and training for primary care, though this is certainly not full integration. And then Horizon Healthcare Innovations that Amit mentioned earlier in the talk. It's a startup created by Horizon, the health plan. It's in early development. And it's a payer-led set of services that work with physicians and care coordinators to deliver primary care medical homes, ACOs, episode-based care models, and consumer engagement platforms, which are still in development. Next slide, please. The purpose of integrating the care setting is in part to improve the continuity of working with individual patients across the care continuum. And so as providers move beyond the acute enterprise, they're developing a set of capabilities that address population health management needs. So if one of the major goals is to prevent acute episodes in the first place, Amit talked about stratifying and segmenting patient populations, directing interventions based on clear care plans. And providers need access to up-to-date clinical information about populations, agreed algorithms for assigning risk stratification. Where I've seen this work requires very deep collaboration between primary care physicians, hospital physicians, and IT systems. It also means collaborating with a wider group of partners. Pharmacists, for example, are the health care provider that see patients most frequently. They can be very helpful here, as can care managers. And there are a number of promising experiments. Even paramedics are being used effectively in some studies. Low technology telemedicine, for example. One experiment I saw took a population of patients whose ED visit rate was about 12% per year. And by using just a very basic telemedicine where people would dial in their vitals and care extenders would respond to them in their homes, reduce the visit rate to the ED from that population to less than 1% per year. Now, we've benchmarked over 400 hospitals across the country on rates of avoidable inpatient admissions as defined by AHRQ, things like dehydration. Roughly 5 to 10% of a hospital's total admissions can come from these avoidable admissions. And as providers get better at keeping these people out of the hospital, they will experience lower volumes and lower revenues. But the good news is that many of these cases are actually margin negative. So efforts here may actually, not in all cases, but may actually reduce some of the burden on your clinicians while raising your bottom line, even in today's fee-for-service model. And especially so in more of the shared savings models of the future. Next, when we think about enhancing decisions about what a care needs during the acute process, should they go to a PCP, to an urgent care center, to an ED, to a specialist? Of note, where some ACOs, especially some of the physician-led ACOs that I've seen are most successful at driving down costs, the simplest and most effective thing they can do is refer patients to non-hospital settings where there are huge price arbitrage opportunities. So in the acute encounter, how can you strip out costs? How can you increase quality? How can you increase patient satisfaction? And then coordination after the fact. Medicare's penalties for readmissions have focused a lot of minds here, but there's still much to be done when it comes to thinking about when the patient leaves the acute care facility. So next slide, please. So I've talked about capabilities in the clinical structure and the coordination. And all of these efforts assume that payment structure will be in place to make the effort sustainable. And this is hugely complicated, of course, not least because you need to keep pushing in today's world while kicking things off in the new. And I heard one hospital CEO call this standing with one foot on a dock and one foot in a boat, and the dock is burning. So whereas today's world of strategic pricing, as complicated as it is, it's at least a familiar negotiation between payers and providers. But building risk management contracts requires a very different strategic approach. Has to do with thinking about where to take on risks, understanding your current profit pools, how these could change over time, identify the offerings that you as a provider can build products around. And once you've decided where you want to build a product, then how do you actually determine the broad set of services to offer? How many services will be covered in an agreement, for example? How much alignment can you create across payers? Just as Amit was talking about the importance to a payer of how much market share they have in an environment is, as a provider, you need to say, how worth it is it to me to create a specific relationship with this payer based on the market share that they have. And so, when you think about all the complexity that this creates, how do you build that in? How do you manage for that? How do you prevent it? And then how do you manage with the regulatory and legal constraints? How do you manage the very complex stakeholder preferences? So next slide, please. Hospitals today are largely devoted to delivering as broad a range of acute services as possible to as many people as possible. But given the compressed margins of the future, many will be competing more directly and will have to differentiate themselves based on where they deliver distinctive service and quality. Also, when payers set up relationships with providers for population health, many are looking at specific types of service. Just as Walmart recently made a deal with selected providers like the Cleveland Clinic for Heart Care, so when you think about population health, it's important to note that payers are willing to think about service lines and discrete service lines. And the question is, where can you create products? Where can you create a value proposition? Where are you excellent today? And so the concept of marketing becomes much more important in this world. Next slide, please. And so marketing techniques can also be used to improve patient health. And I've been struck by actually the number of hospital administrators, physicians who are really worried about how population health penalizes them for things they have no control over. And while you certainly, as a provider have more control over a person when they're in a hospital bed than after they leave, there's still a number of things that physicians especially, as the most trusted professionals in the country, can do to leverage their influence to improve population health. And so this has to do with moving from a B2B approach to a B2C approach. And you think about how some of the great marketing firms in the world do it. And so I've worked with a number of these companies about how to better identify, understand, reach, engage, and influence consumers. And so as patients increasingly take responsibility for health care through larger copays, coinsurance, consumer-driven health plans, and eventually through the exchanges, they're getting more information and transparency, and they're increasingly becoming consumers. Now, the first healthcare companies that I worked with several years ago who are working through the transition were the retail pharmacies and the pharmaceutical companies. And they're trying to enhance the relationship between pharmacists and patients to help improve adherence to physician recommendations. And similarly, as physicians and hospitals take on risk for populations, they need to better understand the mindsets of consumers so they can help overcome barriers to maintaining good health. And so while this is largely a brand new area for providers, there are tried and true marketing techniques that you can start to understand and start to think about, how would this help me take better care of this person that I don't actually have in my hospital today. So next slide, please. When it comes to the different steps along the process, the journey to population-based care, you can think about the time frame. It's months and years to establish the leadership coalition, build the business case, create the blueprint, and then establish the implementation and delivery systems, and then scale it up for the long term. And I'm curious, just if we could go to the next slide, just to have people think about the different areas where you are today. So in this poll that will largely be the end of the formal presentation, we'll be able to take a couple questions. Where are you in your journey to population health? Are you thinking about it but haven't yet built the leadership coalition? Are you designing it where you have a leadership coalition and you're actually just designing the thing right now? Are you implementing it? Is the plan in place and you're simply trying to build it and make it work? Or are you growing it? Are you scaling it up because you've got a mature and working system and you're focused on scale? Let's see, we'll take maybe 15 more seconds to get people to weigh in here. Got 50% of the vote, and definitely seems to be a lot of people thinking about it. The majority of people right now designing it. Very few people are actually in the grow phase. We'll get a few more seconds to get the percentage in a little bit higher. All right, why don't we close it out now then? And so I think it's a very interesting and I think telling piece when we think back to those three horizons I mentioned at the beginning. And as people are preparing for that market turbulence, they're definitely a lot of people thinking and designing, even some implementation, but people are recognizing that the new normal is probably a few years away, and so in some ways that's good news. Because it means that there's time to build and to make these decisions and these very complex systems that people are building. So with that, I think we've got just a few minutes, so maybe we can take a couple of questions. Sorry that there's not more time for that, but would love to take a couple perhaps.
Thank you, James and Amit, for a very informative presentation. We are now going to begin the Q&A portion of the program, and we just have a few minutes, but we do want to get through a couple questions. As a reminder, you can submit any questions you have by typing them into the control panel in the space labeled Enter and a question for staff and clicking Send. We'll answer as many as we can in the next few minutes, and our presenters will actually get copies of questions that we haven't had a chance to address, and they can follow up with you about those. Additionally, if you would like to contact the presenters, you can visit www.objectivehealth.com. and you can find a main number and contact information for the presenters there. So our first question is for Amit, and it says, how do we define patient population, a single health plan subscriber base, all patients in the practice, and how do we define a population in a multi-payer environment where providers' policies are not standardized across all payers?
Thank you for the question. So I think this is it's an important one. It's a good question, and given the time we have, I think I would kind of say two things. So first is, what we're seeing is that to the extent you can define it as all patients in a practice, which would mean a multi-payer effort in many instances, that's where we see the greatest likelihood of biggest impact and success. I think the other thing I would say is that as you think about patient population, there is kind of defining that population for care and delivery of care, and then there's defining that population for payment. Where we can, it would be great to have those aligned, but they may not always be aligned. And so it is important to take those two views. And with care, kind of the greater the scope, the better. With payment, also the greater the scope, but just the reality of the situation is that it may not be as broad.
Great, and I think we may be able to answer just one more question, and I'll open it up to either of the presenters. We had one person ask about what are your thoughts on collaborating with local health departments or institutes of population health, thoughts around how providers or payers may be able to collaborate with them.
So I think that it's something that payers are definitely thinking of. It is definitely top of mind. We think there's a ton of value there, especially from the patient's perspective. And I think the challenge is, how can you utilize that institution or organization as a hub to really help work with patients and potentially deliver care in a new way as well. But the short answer is yes, that is top of mind, and the goal would be to do so because there's real impact there.
Great. Well, thank you to both of our presenters. There are some more questions coming in, but we are out of time, so we'll have to end the presentation. Again, our presenters will receive the copy of the questions and can follow up. You can also visit Objective Health's website as well for more information. So again, I want to thank our presenters for their excellent presentation and for all of you for participating today. We look forward to having you join us at future webinars. This concludes today's program. Have a wonderful afternoon.